It's it's near the end of the year now.
It's very quiet.
Hi, Tanya.
Hello, how are you?
Good, thank you. How are you?
I'm good, thank you.
That's good.
Lots of familiars. Colifela, I see you there.
Good afternoon, Tanya. Good afternoon, everybody.
Gerard, I see you too. Lots of our ongoing supporters.
Hi, Tanya.
Ken, how are you?
Hi, Tanya. No, I'm fine. I'm fine. Yourself?
I'm all right, thank you.
Good, good.
Kerry, I see you there, hiding behind a different name.
How you doing? Sorry, going.
We know by now. Okay, Cindy, you need to let me know when we are ready to go. I don't know how many people are still in the waiting rooms.
I think we are good to go, Tanya. I think some people will probably just fall in as they join.
Okay, perfect. And there's Herman. Herman's just popped up on my screen. Good afternoon, Herman. How are you?
Well, thank you.
Good to see you. Okay, so this afternoon is probably our very last interaction, I would guess, with our community and our members as we move into, I think, a much needed rest for those of us that are going on leave. As they say, this is the year that keeps on giving. And I think the giving is not the part that we really, really want. It's been quite a challenging year for each and every one of us in one way or another. However, we will remain positive that 2021 is going to be a much better year. However, we have TJ Muehleman, the founder and CEO of Secure Data Kit, joining us this afternoon at a very early hour. So we are very grateful for him for getting up so early to join us. TJ is going to be talking about digitizing the last mile in Kenya, using technology to manage and optimize the supply chain of donated medicines. TJ, I'd like to thank you for being here, for getting up so early and for joining us to give our community a really good information session to leave them thinking as they go off into the holidays. And I'd like you to just share a little bit more about yourself as an introduction before you kick off with the presentation. Thank you so much.
Great. Well, everyone, I appreciate you joining me. And as Tanya, you mentioned, 2020 has been challenging, and I hope we can talk a little bit about some of the bright side of things that we've learned in 2020 with using technology to optimize supply chains. As she mentioned, I am joining from Seattle. I'll tell you a little bit about myself. I'm the founder and CEO of Standard Co. and Secure Data Kit. These are global health and supply chain technology companies. I've worked for about 20 years in technology since I left university. I've been building big data systems for some of the largest organizations in the world. But for the last 7 years, I've focused primarily on global health and a passion on how do we intersect technology and impact. How do we take these things that we can build that are used in private industry and apply them to public health to really help people lead better lives. I'm a member of the Neglected Tropical Disease Supply Chain Forum, the WHO Afro Aspen Technology Committee, International AIDS Society Industry Liaison Forum. Those are all very wordsy things that just sort of help reflect what I've spent my time really focusing on is, again, impact and technology. I also enjoy hiking and nachos. I got to throw that in there. I'm based in the US, in Seattle, so I'm very, 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 very far away. And prior to COVID, I would frequently make trips to Eastern and Southern Africa. So not only am I aware of how far away I am from you all, I've made that flight many times that I feel how far away it is, but I miss it. I miss it dearly, and I'm looking forward to some resumption of normalcy to get back over there. I have this picture of my family because as we've all talked about with COVID, you know, we've now conjoined family and work life. So you may hear in the background my two young children, Lillian and Nora, at some point, and I apologize in advance if they make too much of a racket. A little bit about my company. As I've already mentioned, we are Secure Data Kit and Standard Co are two companies, but we really kind of think of ourselves as Standard Co. We do global health technology. We've built data systems, supply chain systems, inventory management systems for some of the largest global health orgs in the world. We work pretty heavily with WHO, both in Geneva at the headquarters and in Brazzaville with the Afro headquarters. Work very closely with CDC, the Centers for Disease Control and Prevention, Ministry of Health in Kenya, Task Force for Global Health based out of Atlanta, and the Bill and Melinda Gates Foundation. You know, it's been really interesting to see how technology in global health has really kind of become a lifesaver in a lot of ways. You know, a lot of data is being captured and a lot of data is being used, but formally and still in a lot of cases is done on paper. And we're seeing a transition to the cloud and a transition to technology that really expedites the use of this data. And I think you're gonna see that here in this presentation. So the challenge, here's the big challenge, and I'm sure most of you are kind of familiar with at least generally what I'm going to say here. We work in a lot of disease areas, but one of the areas we work mostly is in neglected tropical diseases. And neglected tropical diseases, or NTDs, are a family of diseases that are about 20 diseases that affect over 1 billion people a year in over 100 countries. So that's 1 billion people. And these are diseases that many people haven't heard of, but soil transmitted helminths, schistosomiasis, trachoma, these are all diseases that affect many people and kill millions every year. And there's a consortium of pharmaceutical donors, 5 of them, that donate 1.7 billion tablets of medicine every year to these 100 countries. And prior to our involvement, this donation program was managed on an Excel spreadsheet. And so you can imagine, you know, 100 countries, 1.7 billion tablets, I think around 300 shipments every year on a spreadsheet. And so how do you track where those shipments are? How do you make sure they're going to the right place? How do you make sure that they're being used effectively? And then most importantly, how do you manage all this across a consortium of both public and private partners to make sure the most number of people are treated and that these treatments are being used effectively? And so that's where we were brought in to kind of help solve this problem. The solution is called NT Deliver, and at the end of this thing, I'll share a link so you can actually view it, because it's a cloud-based platform that is designed to monitor and optimize the donation programs for over 100 countries and a variety of commodities, both medicine and other kinds of commodities. And it centralizes all of this data into one place, and it automatically does that. And we'll kind of dive into the tools and the way all this works. And even though the presentation is really around Kenya, we'll kind of keep it more high level and talk more about where this is being used. But the really neat thing about this tool is that it sort of brings together all of this data from pharmaceutical partners, from shipping providers, from the World Health Organization, from implementing partners on the ground who are actually kind of deploying these medicines. And the neat thing is that it is cloud-based, so that means it's available anywhere that the internet is available, and it also works without the internet. So if you're going out into the field, which I've done now 3 or 4 times, where you go out into very rural parts of, I've gone out in Kenya, Rwanda, and Botswana. You're out in these rural parts of the country, you may not have internet access, and you can still interact with the tool. You can still see where shipments are. You can still submit data. So it really does get down to digitizing the supply chain anywhere in the world. So now we'll kind of dive into a few of the what does NT Deliver do, and how does it digitize the supply chain? Who uses it? This is an important point. The biggest organizations in the world, the World Health Organization, both in Brazzaville and in Geneva, have really embraced this tool. We're hoping to see other regions embrace it. Out in the Eastern Pacific and Western Southern India, I'm sorry, Southern Asia, but really Brazzaville and Geneva are the big users and have embraced the tool. Merck out of Germany, GlaxoSmithKline, Johnson & Johnson, AZI, Bill and Melinda Gates Foundation, and DHL, all rely on this tool to manage and optimize where donations are for these neglected tropical diseases, and coming soon we'll be seeing other diseases in the system as well, including potentially COVID vaccines. So what are the key features? Like what does digitizing the supply chain really mean from our perspective? Well, this is really around the first piece is planning. So forecasting and optimization, who needs what medicines, where are they going, when will they need them? So this includes both a 3 and 5 year forecast, tracking, knowing in real time, where are the commodities? Prior to our tool coming online, when a shipment would show up to a country, the country often didn't know it was going to come. So imagine ordering maybe a book online and the book shows up and you're like, oh great, the book is on my doorstep. Now imagine that is a container full of 20 million tablets of praziquantel from Merck. That often would happen. It would show up at customs and the country wouldn't know it was coming. And so they'd have to scramble, and it would sort of sit in the customs or sit in a warehouse waiting to be used. There was a lot of slack in the supply chain. And we'll talk about how we use the technology to kind of shorten some of that slack. Reporting. Everybody on this call, I have no doubt, has been asked to generate some report. Maybe do it every week, every month, every quarter. There's a lot of common data that is required of the system, and we've automated most, if not all of that, including visualizations, dashboards, specific dashboards for specific donors, for specific countries. We've done integrations with country databases. So a good example of that is Ethiopia. We're looking to do this with Kenya here soon, but Ethiopia has actually implemented this, where they've integrated with our system and pull the data out of our system real time and deploy that into their own internal dashboard. And then last but not least is sharing. One of the, I think, big breakthroughs in the system is making the data publicly accessible. And in fact, we just released a white paper back on November 5th that I'll share with the team, and they can distribute it, that shows how the public, by making the data publicly accessible, it's made the supply chain more effective and more efficient. And there's a what we call the observer effect. I think by showing this data and making it publicly accessible, it's sort of made the system more efficient. So I want to jump into some specific components of how we digitized the various components of the supply chain. And I think the next probably 10 or 15 minutes we'll be discussing sort of specific features. And I think there'll be time for questions at the end. Correct me if I'm wrong before I get into the features. We'll do the questions at the end. Is that right? Is that the plan?
Yes, we'll do questions at the end.
Okay, great, perfect, thank you. So the first component of this is probably the least, potentially least interesting component of the supply chain. It's probably, maybe sits a little bit outside of what normally would be considered supply chain, but it is worth mentioning. It's the planning section of the tool. So when you're discussing donated medicines, one of the things that, there's kind of 3 components to donated medicines, and is what's the forecast? So what are the countries going to need? What did they ask for? What was issued in terms of purchase ordered and what was actually shipped. And this is a really critical tool that WHO had previously managed, again, in an Excel spreadsheet. It was not transparent. The donors, the shippers had no insight into this planning tool. And so we were able to centralize all of this data. So again, from forecast, from the 3 to 5 year forecast, all the way to what was actually shipped and delivered, is all centralized in one place, so that you can see what medicine has been requested from what country, or what did we think they were going to ask for, what did they actually ask for, and what was actually shipped to them. And the reason this is so important is that we're able to now kind of start doing trend analysis in terms of forecast. What did the countries ask for, and start to anticipate better what's coming. And this has had a cascade effect to the pharmaceutical donors, so that they see what is coming in several years, so they can capacity plan. And that has been a huge help for them. As you can see on this screenshot, you can search and sort. All of this is available on the cloud-based tool, so you can search by years, you can search by regions, and these are WHO regions, by countries, and by programs. And the interesting thing is that the tool is designed to be programmatic, and by that I mean, in the world, in the donated medicine world, there's various diseases that have different drug combinations, and so you can say, for this disease, what is the forecast, and it'll show you the different drugs and different commodities that fit into that program. So that allows them to kind of group things very nice and neat. Tracking. So this is probably the most frequently used component of the system, and this is really, I think, one of the most interesting innovations we've created. The ability to see at any given time where a shipment is, where it's going, and whether or not we think it's going to be on time or not. And the on time status actually is way before its actual shipment. So for example, this particular case is 3 million tablets of praziquantel going to Niger in 2019. And it's being shipped, it's donated by Merck. And when we receive a request for medicine, so this is way before we actually, way before a shipment is a purchase order is issued, way before it's packed, way before it's shipped, we start to calculate how on time, what its likeliness of being on time is. And we do that through KPIs, or key performance indicators. And so we have 14 different KPIs that are configurable by donor, that are configurable by country, and configurable by medicine. Because every country obviously has different customs rules. Every country has different personnel who are maybe responsive or not responsive. Every drug has a different, some of them are packed rather quickly and some of them are not. And so what we've done, and this again has been a big kind of revelation to both the countries and the pharmaceutical donors, is that we are able to assess the likeliness of this shipment showing up on time. And we'll talk a little bit at the end. We have an impact slide where we talk about the results of the system, because the system's been online for 2 years. So we can actually see how effective these KPIs have been, and they have been rather effective. Other features of this particular thing is that we have all of the shipping documents that are sort of located in, or centralized in one place. So if you're looking at a certificate of authenticity, or if you're looking at a donation letter, you're looking for a packing list, a lot of these documents are required upon entry into the country. You have all of them in one place. And then the last thing that's really, I think, a good feature is the ability to view the audit history of a purchase order. So you can see all of the changes that have been made to this purchase order and by whom. And that's both humans that have changed the data as well as the software. And so it's really neat. We have a variety of different bots or programs that are interacting with the system, maybe changing data as new information flows in, or updating the purchase order, or what have you. We have these bots that sort of, you would show up and say, TJ changed this, or the email bot changed something. And it's really been an effective tool so that somebody can see, well, wait a minute, a booking was made on the 28th of December, but now it's changed to the 30th of December. Why did that change and who changed it? So that kind of thing has proven to be very, very helpful. And as it relates to digitizing the supply chain, as it relates to Kenya, again, all of this data is now available on a platform that Kenyans and other countries, the other countries who are using the platform, can interact with. Both, they can come to the platform and view it online, and they can actually integrate with it and pull it into their own system, which I mentioned earlier. Ethiopia has done that, and a few other countries have done that, and Kenya will be doing it soon. So this is all starting to set up the kind of where we're headed with the last mile, where you have to have the digital components for the first mile, and in the humanitarian logistics area, this kind of tool is fairly rare in terms of its open access and its ability to allow countries to integrate with it. So we're setting the stage, so to speak, to see the last mile here in a moment. Coordination. So one of the things in the donation space, and I'm not sure how many people on the call are work in donated or in humanitarian logistics, but in the humanitarian space, you frequently see coordination in terms of who's donating where, or who's working with what country. And for example, this is a map we have created that shows the different countries that in Central and Eastern Africa that are being worked with. A variety of partners might be donating to the DRC, for example. And before this tool, they would just sort of call each other and say, hey, what are you sending over to DRC? I'm sending 10 million tablets of whatever. Okay, great. I won't send 10 million because you're doing it. And it was a very informal and a very ad hoc experience. And so because we have all of this data around forecast and all of this data around what's going where, we're able to paint a picture of where are donated supplies going and to what countries. And coming soon, you can see, like on this map, it's just a country by country map. We have a subnational tool that's coming, and it's actually, we'll talk a little bit about that in the last mile pieces, but the ability to not only say I'm sending something to Kenya, but I'm sending something to Migori County, or I'm sending something to Homa Bay County. The ability to kind of really dive into that last mile and understand what are the needs in those counties and districts and what has already been sent there. So that way we have a much better coordinated effort to those parts of the world. I mentioned automated reporting. One thing I think that we do well is we really understand the needs of the consumer. My background before doing global health was working in consumer systems. And by that, I mean, we're developing systems for millions of people. So when you're developing systems for millions of people, you really have to understand what their needs are. You have to really understand who the user is. And to that end, in global health, we spend a lot of time, even though I'm based in Seattle, as I was telling the team earlier, I'm up at 5 a.m. almost every day working with colleagues, and again, mostly East Africa, Eastern and Central Africa. But I spend a lot of time on the ground there. I spend a lot of time in Ministry of Health offices. I spend a lot of time in the field using smartphones with the teams who are actually implementing these programs to understand what kind of data do they need? What data do they have? And if you don't actually get on the ground and get out in the field to see what people are doing and what their needs are, it's hard to really understand what data can you provide them. So we've really spent a lot of time understanding that. And to that end, we've provided a number of automated reports based on that feedback, a number of automated dashboards. The system allows us to kind of easily provide that data to them, both on a desktop as well as a smartphone. Okay, in the last mile. So leading up to this, we've been talking about how do we track what medicines are requested by what countries, and we'll use Kenya as a good example. Kenya has I've worked with them. I've spent a good number of days and weeks on the ground in offices, both in Nairobi and out on the coast, and really understanding what is the situation with donated supplies there, what are their needs, and how do we optimize, really truly understand where do the medicines need to go. And so the kind of last capstone to this tool is this last mile inventory that takes this data of requested data drug treatment request data from the first mile, and sort of overlay it and add the last mile to kind of paint a holistic picture. And the really cool thing is that we rolled this out. We've been doing last mile work in Kenya for 4 years now, and it started as an SMS tool, and I'll tell you a little bit about that tool, and we'll kind of get to this one. The SMS tool actually was deployed to 2,000 schools in Kenya, and for these drug programs, they're actually frequently deployed in schools because they're used to treat children. Most of these drugs that we've talked about, these 1.7 billion tablets, the billion different people who are affected, they try to capture the preventative side of it in young children, as young as 5. So I've actually been to the schools, and what they would do is they would give out tablets to children, and then they would use SMS to report the data back to us. And that was a really effective tool when the data collection was really simple. And by that, I mean, we were capturing one indicator. How many tablets did you give out? The tool worked great. We were very successful. We had very good data. We were able to shorten the amount of time it took to get that data from by paper. It would take as long as 18 months to get that data, to as short as 30 days when we were doing it via SMS. It was very effective. The tool stopped working as effectively when we added multiple indicators, because as you can imagine, SMS is a really good sort of one-way and unidirectional tool. And by that, I mean, you ask one question, you get one response back. When we added multiple indicators, we started asking how many children were treated, how many of a different medicine, and we, I think, got up to 5 different questions. The quality of the data broke down, and it revealed some assumptions we had made about access to internet and cellular connectivity in rural parts of the country. It revealed that we had made some assumptions that it turned out to be incorrect. And it showed that there was an ability to migrate from an SMS-based tool to a smartphone-based tool. And we did that this year in the middle of COVID, which was kind of shocking. And it turned out to go very, very well. And so the tool migrated to just a web-based survey, where instead of doing SMS, we would send a WhatsApp link or an email link to these providers and ask them a series of questions. And so by moving it to a web-based, what we were able to start doing is we were able to structure the questions in a more effective way, and we were able to get much higher quality data that way. And in fact, the SMS data cleaning took us about 30 days to kind of get the data where it needed to be, whereas the smartphone data cleaning took less than a week. So what we were able to do was able to kind of coalesce all of this data to paint a picture for, in this case, 2 specific counties in Kenya, Migori County and Homa Bay, which are out near Lake Victoria. And these 2 counties have each 8 districts or sub-counties. And what we were able to do is we were able to engage the county pharmacist. So instead of the teachers, we were engaging the county pharmacist to say, how many tablets of a certain drug did you receive from the country, from the central medical store? How many did you distribute? And so we're able to kind of do some simple math and say, okay, well, you received 1.2 million tablets, and you have 451,000 left. So therefore, you used, whatever that math adds up to be, 800,000 tablets. And so we're able to kind of do some basic math, and from there, we're able to estimate how many people were treated. this treatment number, this 312,000 number and 184,000, these two numbers, again, we were able to get for these two counties in about 2 weeks. 2 weeks. So from the moment we issued the survey to the moment we were able to tell the Ministry of Health how many people we estimated to be treated was 2 weeks. Previously, this would take months to get to the ministry, data cleaning at the ministry, and then another year to get to WHO, to get to the pharmaceutical donors. And so the supply chain, by shortening this amount of time, this allows the upstream donor to better capacity plan, and allows WHO to better understand what is happening. And most importantly, it allows the ministry to really understand where resources need to be deployed. It allows them to really think through reverse logistics. So for example, taking medicine from one district and reallocating it to another. And we were able to build these maps and these charts, and this dashboard was updated real time. And so what, we were expecting the Ministry of Health to be kind of pleased with this, but we didn't expect them to use it because they're busy people. And they actually use this quite frequently. They used it both as an accountability tool to see what districts had reported their data, and they used it in conjunction with the implementing partners to help redeploy medicines that were unused in some districts to other districts that needed it more expediently. So this whole thing, again, from the first mile to the last mile, is all about how do we take data and centralize it? How do we take data and make it actionable, and then make decisions based on that data? And the next few slides, we'll kind of talk about what are some of the results that we've seen from this data. So what is the impact of the tool? So the tool, we started building it, as I mentioned, we were first retained or brought in about 5 years ago. And then the tool went live in 2017. And so that was sort of a pilot year. And then 2018 was the first full year of real data that we had. And we've constructed this timeline. And I was actually in Geneva with the World Health Organization in February of this year. This is, I arrived back in Seattle about a week before COVID really caught fire here in Washington State and in Seattle. So I was actually presenting this in Geneva this year to kind of show how effective the tool is. And what we've been able to do is, because we're measuring every specific little KPI, as I mentioned earlier, we're able to track from application submission, which is when the country requests medicine, to MDA, which stands for Mass Drug Administration. That's when the drugs are actually used. And so this is a really good chart that sort of shows each individual component, how long it takes, and where did we see gains. And I think that the key takeaway is that in 2018, from the moment an application or a country asked for medicine to the moment it was actually deployed via a Mass Drug Administration, it was about 9.52 months. And one of the real challenges with this kinds of this volume of medicines that are being deployed and the timeline is that medicines have to show up actually about 9 months before, or the request needs to be made about 9 months before the administration for them to show up on time. So we were in 2018, we could tell that we were actually trending late every single time, and that's an obvious problem. In 2019, we were able to kind of, using this data, demonstrate where the bottlenecks were, demonstrate what needed to change, and we'll talk a little bit about a couple of things that changed, to shorten the timeline from 9.52 months to 8.45 months. So that means we were, in 2018, historically, almost most shipments were late. And in 2019, we were able to shorten that so that now most shipments were not late. And we were able to do that with data. We were able to acknowledge, or not acknowledge, but highlight where the bottlenecks were and highlight what things needed to change to make sure these deliveries happened on time. And this really kind of is reflected in a couple of key stats, on-time performance. we saw a 37% improvement in on-time performance. Again, in 2018, I think it was about 37% of shipments arrived on time. And in 2019, that's now over 50%. Again, you might be saying, wow, only 50% are on time. You know, this is the humanitarian world. And there's a lot of moving parts. And that's a pretty significant improvement. We were really excited to see what was going to happen in 2020, but obviously 2020 is going to be a year that we probably just kind of toss in the waste bin, because a lot of shipments, WHO issued a stop on shipments and mass drug administrations for a significant portion of the year. So there's no telling what the data is going to show this year. The other thing that we were able to do using the data, and this was something that anecdotally the donors obviously knew, but we're able to kind of highlight in the data that one of the biggest problems, the purple bars here kind of show when purchase orders were issued, and so you can see in 2018 it was really kind of jumbled up here in 2 different months. And so this basically meant that the countries were all doing their mass drug administrations really in kind of 2 months of the year, 3 or 4 months of the year. And that meant the demand planning was really hard. And what we were able to highlight is if we flattened that out into something a little bit more evenly spaced throughout the year, that we would get a much more effective, and the donors would be able to more effectively pack and ship all of the medicines. And so that went from about 56% of all purchase orders in 2018 in 2 months to 26% in 2019. And so, you know, this is just a couple of the data components, or a couple of the indicators that we watch and we track. There's a variety of others that we work with both WHO and the ministries of health around the world and in Kenya, that we help highlight this data, and we help kind of point out where the problems are. And I think one big takeaway from all of this is, I think one thing that we've done well is we sort of set very clear and simple, measurable ways we can impact the supply chain. Again, just understanding what is happening, and being able to say this thing takes longer than it probably should. You think it should take 10 days, but it actually takes 20. And by measuring these things, just by measuring them, we're able to kind of understand where improvements can be made. And I think that now, you know, we see that in the last mile, where again, in the humanitarian world, we're seeing a lot of drugs that are being shipped to these counties that probably don't need to be shipped there. You know, we're shipping enough medicine to treat 2x the population that's there, and that's just because it's always been done that way. And now we're realizing, well, it doesn't need to be done that way. We can optimize this and make it more efficient. And at the end of the day, in the world that we work in, it's really about how many more children can we treat, how many more people can we treat, and how do we make sure that they're treated on time and treated the most effectively. And so I think this tool is really, at the end of the day, is really aiming to do all of that. With that being said, there's a couple different places you can go to get more information. You can go to ntdeliver.com. It is, again, a web-based portal. You can access it on your computer. And in fact, if you're just sort of curious, whatever country you might be in, again, primarily in Africa and Asia, you can actually see what shipments have been sent to those countries. That's publicly accessible information. And you can just kind of get a feel for what the tool does. It is a tool that we can deploy to other programs, and we can deploy it to both private and public industry. So if you're interested and want to talk to me more about that, please reach out to me. My email address, my phone number, and I'm available on WhatsApp. I'd be more than happy to talk you through it. So I think that leaves us about 15 minutes for questions.
Hello. Okay, I'm back. Do we have any questions for TJ? I'm not seeing anything coming through in the chat at this point. Any questions at all? Everybody's very quiet. So I think everybody's going into holiday.
Going into
Okay.
holiday mode.
Yeah. Joyce, you have a question?
Yes, I do. Hi, everyone. My name is Joyce. I am from Nairobi, Kenya.
Hi, Joyce.
I work for although I work for an international humanitarian NGO, I think this is very interesting to see what you're doing in my home country with the Ministry of Health, understanding very much the settings and the challenges within the health system and structures here. Just one question though, wondering how do you collect data from the end user? Because then I would imagine your end user is the clinics and the hospitals and maybe the community health workers who are in direct contact with the patients.
Yeah.
Another question, how do you ensure accuracy of that data? And do you have challenges like variability in demand, and how do you arrest that? Thank you.
Those are great questions. So there's a couple of different questions. How do we capture data from the end user? So we actually, there's two ways. One is through SMS and WhatsApp. And so what we've done is we've created a really simple bot that can engage with the end user. And so the implementing partners, the NGOs, have their phone numbers and they supply them to us. And we have what's called a zero-rated short code in Kenya, which basically means there's no charges for the end user. We absorb all the charges. It's free for them. We pay the price to send them the text message. So we can send them a text message, or we can send them a message via WhatsApp. It just depends. And so we will collect data that way. The challenge with that method of data collection is the data quality is lower because it's very difficult to do validation on that data at that point. So for the end user, it is an SMS based thing, and it is touch and go on the quality. From the clinics and from the central medical stores and the district medical stores, we use a smartphone app that we have created, which allows us to get much higher quality data and allows us to kind of implement some sort of validation rules against that data. Like if somebody submits, I deployed 2 billion tablets, obviously they wouldn't deploy 2 billion tablets, that's impossible. So we can kind of capture that there. How do we confirm the quality of the data? Really good question. So what we've done over the 4 years that we've been doing this in Kenya, in the schools in Kenya, is it's been a parallel process of collecting the data on the smartphone and SMS, and collecting it on paper, which is the normal process, and then cross-checking that data. And what we noticed is when we were only collecting one variable, like one piece of data, the quality was very, very good. Once we started collecting multiple variables on the SMS, the quality went down. The good news is with smartphones, we haven't seen a degradation in quality, just because there's a lot more constraints, and we can follow up with the user much more easily. So hopefully that answers your questions.
Yes, it does. I'm just trying to relate with what we do at my place of work. I work for the ICRC. At the end user level, we have a tool that is called like an impressed file, an impressed tool, which is just basically an Excel file where they record, they have an impressed value, which is, quantities that are required at any given time. So then they record what has been consumed, and then are able to know what to order based on, the values. So do you have something like that on the ground level? Because one big challenge for the end user is, maintaining that data, because then in wrong data, definitely it has a ripple effect upwards.
That is a very, very common problem. And in this particular tool, we have not dealt with that exactly, but in other tools that we've built, because we do other global health technology tools, we have dealt with that issue. And specifically with WHO Afro, we have a tool that allows countries to centralize this data as opposed to centralizing it in Excel. It's centralized in a cloud-based database. And you and I can, if you reach out to me after this, I'd be more than happy to talk you through how we've handled that problem. But it's not really, NT Deliver is a tool that sort of picks up after procurement has happened, after kind of making the request has happened. We kind of track everything else, but we've built other tools that do the first part. And so I'd be more than happy to talk to you about that.
Very much.
I have another question here from Lisa. Please, can you explain your data security protocol?
Yeah, wonderful question. So we have kind of a couple of different approaches to this. So we have sort of data governance. And so we're always very clear that we are an organization that works with organizations to capture and manage their data, not our data, their data. So none of the data that we capture, which at this point we do have a substantial amount of data in our system, is our data. We don't anonymize it, we don't sell it, we don't repackage it. It's not our data to do anything with other than what we're asked to do with it. So from that perspective, we govern the data with the utmost kind of quality. The second piece is certain countries have certain, one of the challenges when you're building a system that is used to manage 100 countries worth of data is that every country has its own sort of standards and its own protocols. For example, I'll use India as an example. India has a very high standard of what data can be housed outside of the country. And so the data is captured on our system, but is fairly quickly sent to them for approval. And then once they've kind of approved it, then it can stay in our system, or it will then kind of exit our system. Other countries sort of have similar kind of standards. So from that perspective, we always engage countries on what their requirements are. So we don't assume that because we're a US-based company, they have US-based standards. And in fact, I trust my colleagues in Africa with data more than I trust my colleagues in the US with data. That's a longer story we could talk about over beers sometimes. But we engage countries in terms of what their standards are, and we abide by those standards. And then from a security standpoint, all the data is encrypted, both in transit. The only trick is that SMS is a little bit, because it kind of sits outside of our system. So we kind of have to rely on the cellular provider to have some level of security, but that's completely outside of our control. It's not even within our control. But all of the other data components, whether if it's the smartphone, because we can encrypt that, it's encrypted at rest, and we have automated backups and a lot of other security protocols I can share with you after this meeting.
Thank you, TJ. I have a question. How much data transactions are you talking about? So if you're receiving data through SMS and smartphone,
yeah,
I imagine that must be a massive amount of data.
Yeah, I mean, right now, our system as a whole, so both for NT Deliver, but other systems, and this is data that's pre-COVID, and I'll share you this stat. This is kind of a fascinating stat. So prior to COVID, we would transact about 100,000 surveys a week. And surveys might include, anytime somebody submits a form, anytime somebody sends us data. So that's 100,000 surveys. And the biggest survey is 400 data points. And the average survey is something like 25 data points. So you can get a feel for how much data is flowing through our system. It's a substantial amount of data. And that was March 15th. I actually was looking at this recently. So March 15th, 100,000 surveys or 100,000 data submissions every week. When WHO put a stop to all of the data collection and field activities, we saw that number plummet to about 2,000. And it hung out there until about middle of October. And in middle of October, the restrictions were sort of lightened up. I have a feeling they're coming back, obviously, with the spike in COVID, and WHO being a little bit more cautious with it. But yeah, about 100,000 every week.
Okay, one more question for you before we wrap up, and this is purely for my interest. The impact of a vaccine. How will that amount of material affect the supply chain, especially in last mile delivery? So I mean, if you're looking from an African point of view, I mean, you know, we will probably be the last people to get vaccine if after US in Europe. But I mean, what sort of effect is that going to have on supply chains and being able to manage that?
Yeah, so a wonderful question. I think there's a couple of approaches that are happening there. One is the vaccine. You know, we're actually in discussions to use this exact tool to manage, or at least manage the vaccine deployment from a digital perspective to the last mile in Africa. So hopefully NT-Deliver will be that tool and that visibility tool into where the vaccines are and where they're going. What impact is it going to have on the supply chain? That's a great question. I have no idea, but I can't. It will be significant because already, even prior to the vaccine, the supply chain, and I think we'll know more next year how big the impact has been on the supply chain. It's been significant. The biggest problem that we've seen with the pharmaceutical donors is that they're manufacturing. It's not something you can just wind down the production of 1 billion tablets. Like it's not a button you push to stop it. And so what has happened is that there's a significant logjam of medicine sitting in warehouses waiting to be shipped, and there's no shipment, right? And you're going to see the same thing. Vaccines are going to sort of jump to the head of the line, and so you're going to see a lot of things sort of back up. And the real challenge for some of the medicines that we manage is that the expiry dates are fairly short. We're talking 15 to 18 months. So you've got medicine sitting on a shelf that already, because the supply chain takes about 9 months, so you're cutting into half of its lifespan just in getting to the country before it's even used. So now it's sitting in a warehouse somewhere. And so, I think you're going to see a cascade effect for the next 2 to 3 years, perhaps longer, affecting the supply chain and affecting the deployment. In my world, the thing that I'm most concerned about is I'm obviously very concerned about COVID, and I'm glad we're dealing with it as the way we are. But the thing that concerns me is the full stop that we've put on other global health programs. It's not good, and the supply chains are reeling from that.
Yeah, it's I think COVID-19 has still far-reaching consequences that we don't even begin to understand, and I think that other conditions or health priorities are going to take a backseat. So somewhere along the line, somebody's going to suffer as a result of it.
Absolutely, yeah.
The COVID vaccine will jump the queue, but then other people are not going to receive medication they need. So it's going to be a difficult time, I think, for supply chains to get their act together and, streamline, prioritize. I just don't know. I think that wave or that tsunami is still coming.
It's definitely still coming.
We'll watch that space. So TJ, thank you so much for your time and that interesting presentation. The data, the information, it's incredibly informative, especially with the amount of information you're processing, the countries you're working with, and the amount of data that you seem to be sifting through on a regular basis. A big thank you to everybody that joined us this afternoon. I know that everybody's trying to wrap up their year and wind down into holiday mode, which I hope lots of you are going to enjoy. For those of you that are still working, all the best. But thank you to everybody for your support of SAPEX this year. And we look forward to lots more interaction and engagements and exciting community projects and activities in 2021. So thanks for being here. All the best to everybody, and we will see you all soon. Take care, everyone.
Thank you so much.
Thank
very
you,
much.
TJ. We can publish your slides
Yes, please.
and the recording as well.
Yep.
Okay, we'll post that on our YouTube channel for everybody.
Thank you.
So if you want to have a look